Hello everyone, this is Professor Flourish. Today in Medical Surgical 1, we're going to be talking about Chapter 4. Chapter 4 is Concepts of Care for Older Adults. So basically, this chapter gives you an overview of how to take care of older adults and certain considerations to think about when you take care of them. Realistically, most of the patients we come in contact with are going to be geriatric patients or your older adults. So you'll see them referred to as geriatric, older, and elderly. Geriatric syndromes are these major health issues of the older adults, also referred to as elders. So these major health issues are things that we want to take in consideration. For example, something like that you learned about in pharmacology, polypharmacy, that a lot of these older adults may have multiple doctors that are prescribing to them. There's also some other consideration. Basically, in your book, they've got these little boxes that highlight these key considerations for older generations. And what I would suggest is reading those whenever you learn about a new topic. Because, like I said, most of the population we take care of are going to be your elderly patients. So you want to kind of think about how this medication may affect them opposed to a younger patient. This is once again just an overview. We've got what's considered our different groups of older adults. We've got our baby boomers, our in-betweeners, and our patients that are over 100 years old. So these are just people who are considered elderly. So some of the health issues for older adults in community-based settings are things like COVID-19. So with COVID-19, older adults had the highest rate of hospitalizations and death until the vaccine was available. Older adults who were obese and had more than 3 chronic conditions had the most negative outcomes. Now, we see this with most of our disorders. Usually it's either the very young or the very old. Um, so that's something to take in consideration as well. We also have social determinants of health. Rate of hospitalizations were disproportional. So basically, what this means is patients of certain nationalities had a much higher rate when compared with patients that were Caucasian. So it was very disproportional. So the other thing that you want to think about is Medicare and Medicaid really like to talk about health promotion and disease prevention. It's a lot cheaper for us to be able to prevent a disease than it is for us to have to basically take care of a disease. So a lot of the literature, a lot of what we're doing now is kind of moving towards this prevention, where we want to prevent people from becoming sick. And some of that has to do with your health literacy. So health literacy is basically the degree to which a person has the ability to obtain, communicate, process, and understand basic healthcare information. What I will say about it is just because somebody has the material does not mean they necessarily understand the material. So with technology, with the growing of the internet and everything, we are given a whole lot of information. Some of this information is true, some of this information is false. One of the things we do as nurses is to help guide patients, to help them understand which is the information that is the correct information and which is the ones that they need to steer clear of. So, what I always say is when you go into a situation, just kind of treat everybody the exact same. Treat everybody as if they may not know to the same degree you know. Now, that doesn't mean to be facetious about it. Don't be rude about it or anything, but just understand that there's just a lot of information and it's very difficult sometimes for people to have that basic understanding of it. This leads into the next thing of health equity. So I've got a video on here that talks about health equity. It's also on Momentum, and feel free to watch it, but it basically just goes through that sometimes there's people who are not born into the same situation as others. So it's a little bit more difficult for them to have things like access to health literacy. It may be something along the lines of I grew up in a very urban area, so I have a lot of information given to me all at once, or I grew up basically way out in the middle of nowhere. I don't have internet, so I don't have as much information as someone else. So the whole idea behind it is trying to make it as equal as we possibly can. So with this health promotion and disease prevention, so these are some of your common health issues and geriatric syndromes. I'm going to go through all of these and kind of talk to you about them, but there are certain ones that are highlighted that we're going to go into a little bit more depth. So some of the common health issues are inadequate nutrition and hydration, decreased mobility, stress and coping, falls, medication use and misuse, impaired cognition, substance use disorder, and elderly neglect and abuse. So these are common health issues as well as your geriatric syndromes. Now, with this, things that you always kind of want to take in consideration with your older adults is your nutrition and hydration. So, are they getting adequate food? Is there a reason why they're not getting adequate food? Is there a reason why they're not hydrating? Mobility. So they are going to move slower. What can we do? Because you can kind of relate mobility with something like falls. Cognition can definitely be related to things like medication use or misuse, because maybe they just don't understand what we mean when we use the term PRN. So you have to kind of be careful with the language you use because they may not have the same background as you do. So like I said, we're going to go into a little bit more detail. Inadequate nutrition and hydration. So they have an increased need for calcium, vitamins A, C, and D. So some of the factors that we want to think about is they're going to have diminished taste and smell. So since they have diminished taste and smell, we need to be making sure that we're labeling everything. For example, if I put bleach inside a container, it's clear, it looks like water. If they've got a very diminished taste, a very diminished smell, they may not know that it's bleach. And obviously, we don't want our older adults drinking bleach. So you just want to make sure that you're taking consideration whenever you are going through home safety. It always comes back to safety. Tooth loss and dentures, making sure that we've got really good oral care. I cannot stress oral care enough. It was always one of my pet peeves is when people would skip the oral care. I guess it's just because for me personally, I don't like to have like a dirty tasting mouth. So I can only imagine what it's like for these older adults who have these dentures that are filled with all kinds of gunk because we're just not cleaning it. So make sure that you're being proactive. Constipation. Remember, as we get older, everything kind of slows down. So you want to assess these patients for constipation and always start with the least invasive thing and move to something more aggressive, something more invasive. Limited income. A lot of these patients are older adults. They're retired. They have a set income. They can't really afford the things they could back when they were working. Chronic disease. Diseases are very, very expensive. So that comes back to I've got a limited income and now I'm paying for this chronic disease. Fatigue. Inability to perform ADLs. Even without having a chronic disease, as we get older, things slow down. It becomes more difficult for me to do the things I could have done back when I was a lot younger. Social detriments of health. That's where I was talking about that there's certain um, groups that may have a more difficult time accessing care. Loneliness. Something that you want to take in consideration when you go into clinicals is for a lot of these older adults, you're the only person that they've talked to in months. It can become very, very lonely. Maybe their spouse passed away, their kids are older now, so they don't come to visit them as much. So when you go in there, make your time at clinical very, very meaningful because sometimes you may be the only person they talk to for another couple months. So they can get very depressed, very lonesome. So when you are assessing for inadequate nutrition and hydration, these are some of your nursing interventions. So the first thing you want to do, like always, assess your patient. Remember, first, that's what we talked about, previously, if you watched my other video about tips for Med-Surg 1, is you always assess first. Whenever they say, what's the first thing you want to do? Assess your patient, check on your patient. So some things that you can do to assess them is what is causing your patient to have decreased nutritional intake? So you want to ask yourself all of these questions. Is there an underlying GI issue? Do they have a history of an ostomy? Do they have a history of colitis? Is there something that may be causing them to have decreased nutrition? When was the last time your patient had their teeth cleaned? I know I keep on stressing this thing about the teeth, but I guess it's because I've seen so many different patients where we would be really worried about nutrition and our patient wouldn't eat for like a couple days and everyone would be like, why aren't they eating? Should we start talking about a peg tube? What's going on? And my first thing, even when I was a charge nurse, or my first thing of when I was working with these patients was, when was the last time we looked at their dentures? Have we assessed their mouth? Is there something that I can do to clean their mouth? And I actually had one patient where I cleaned her mouth, and after I cleaned it, she was willing to eat. Because just think about it this way. I know I personally can't go without cleaning my teeth so often. So imagine what it is for them who may be going without cleaning their teeth for weeks on end. Maybe it's a cognition issue where they forgot to brush their teeth. Do their dentures fit appropriately? Because that's the other thing too, is if these dentures are very, very painful when they eat, are they going to eat? No. Do they have any religious preferences that may need to be discussed with dietary? So the other thing that can happen is, let's say they're not supposed to eat pork with their religion, and all we've been giving them is pork. They're obviously not going to eat it because that goes against what they believe religiously. So you need to make sure you're asking these questions. Is there a medication that is causing GI upset? Is there something that's making them feel nauseous? Is there something that's making them feel like stomach pain? If there is, can we give them another medication to help avoid that? Is there something that we can do on our end? Or can we reschedule this medication after talking to pharmacy, talking to the physician, and maybe have it at a different time than mealtime? The second thing you want to do is analysis. Patient complains about their mouth feeling dirty after completing an oral assessment. So what am I going to do? I know that my patient's mouth feels dirty. What am I going to do about it? Sorry, I had to change gears a little bit. So yes, analysis is I've assessed their mouth and the patient's complaining that their mouth feels dirty and that they maybe don't want to eat things, or they're very specific, like they only want like softer foods or anything of that nature. So I've already done my assessment, or I'm noticing these things. I'm going to go back and assess them. So analysis is patient complains about their mouth feeling dirty after completing an oral assessment. So third thing you do is plan. So what am I going to do about it? First thing I did was I assessed my patient. I did my oral assessment. I noticed that they may have dentures that aren't fitted correctly. So that's what that analysis is telling me. Third, I'm going to plan. So now I may talk to the physician about it, or we may talk to the family about it, or we may do oral care. It all depends. So that's where your fourth one comes in: implementation, intervention. I'm going to clean the dentures. And then finally, 5, evaluation. Did your intervention work? If not, you start over. So like I said, we'll use the example of my little old lady. So I noticed that my little old lady, her weight's going down, and it's not like she has any underlying disorders. I looked at all her labs. There's no underlying disorders that may indicate why she's losing weight. And when I talk to my CNA may tell me things like all she wants to do is eat pudding all day. She doesn't want to eat anything other than pudding. So as we know, she probably needs something that has more nutritional value than just pudding by itself. So the first thing I'm going to do is assess her. I'm going to look at her dentures. I'm going to look inside her mouth and see, is there anything that I can do to help fix this? So when I assess, I notice that her mouth is very dirty. So that's where that analysis comes in. After I analyze it, after I kind of decide that that's what the problem is, the next thing I'm going to do is plan on what I need to do next. So what I need to do next is I know her mouth is dirty. I'm going to clean said mouth. So that's where I do my interventions. And then finally, I ask, does it work? Is she willing to eat something other than just pudding? And that's basically what you need to do with any of these things that you come across is here's my assessment data. What does this assessment data mean? What am I going to do about it? Here's what I'm doing about it. And did what I say I'm going to do work? Okay. So another thing, continuing on with this, is adults older than 65 are at an increased risk for dehydration related to, and that's what that R/T means, having less body water content and decreased thirst. So physiologically, they do have less body water content. Psychologically, a lot of times, because it comes back to their cognition, their thirst receptors are just not telling them they're thirsty. So it may be one of those things where you have to remind your patients that they're thirsty. Another thing is they've got these nursing actions. So something else that is very helpful in your book is these nursing safety priorities. Remember what I told you guys, safety, safety, and more safety. Whenever you see a safety consideration, that's one of those things you want to put a star on. That's one of those things that you want to know what to do for these patients. It may not necessarily come up tomorrow, but it is something that will come up eventually. So on page 61 of your book, basically the quote on here, because I don't know if you all can read down there, it's very small. Older adults sometimes limit their fluid intake, especially in the evening, because of decreased mobility, prescribed diuretics, and urinary incontinence. Teach older adults that fluid restrictions make them likely to develop dehydration and electrolyte imbalances, especially sodium and potassium, that can cause serious illness or death. So looking at this, going back to our considerations, one of our considerations was decreased mobility. Our older adults, they know that if they fall, like a lot of our older adults know that if they fall, it's going to get them a one-way ticket to the hospital. They don't want to go to the hospital. I don't know anybody who really wants to willingly go to the hospital. Now, you might find somebody who does, but majority of people do not want to spend their weekend at the hospital. So since they know that at nighttime they're a little bit weaker and they have decreased mobility, their thought process is, if I don't drink, I won't have to pee at night, and then there's my problem, I won't fall. What is the problem with this? The problem with it is by limiting their fluid intake, we can put them into a fluid imbalance. We can basically, they can cause themselves to become dehydrated because they're not taking in enough fluid. The other thing is your prescribed diuretics. So with our prescribed diuretics, ideally, and this comes back to pharmacology, when is the best time for them to take a diuretic? And you can pause the movie. You can pause the video or however you want to do it. Do like Dora the Explorer, pause for a second and think about it. Diuretics. When do I want diuretics? Day, morning, AM. Always think of diuretics D for day because you want it in the AM. Because diuretics in their nature is going to make them pee. So what can I do to help my patient is I'm going to give that in the day to prevent them from having to pee at night. And the other thing is urinary incontinence. So urinary incontinence can be very embarrassing for your older adult. And if you remember what I talked about before, with their loneliness, being by themselves, they don't want to have to deal with this incontinence and make it so even less people want to talk to them. It's why when you get to an older adult and maybe they don't smell appropriate, just be polite about it. Don't be like scrunching your nose up or anything like that because they're already dealing with enough as it is. So the main thing about the safety priority is unless the physician orders for them to limit their fluid intake, or unless they've got some sort of disorder to limit their fluid, do not let your older adults limit it based off of being scared about being incontinent or being scared that they won't make it to the bathroom. Going on to decreased mobility. So with this decreased mobility, like I said before, your older adults are already kind of more inclined to be less active than your younger adults because as you get older, muscles become more fatigued. And so they just, in general, they just aren't as active. So that being the case, you kind of want to provide them with things that will increase their mobility. So these are some advantages of physical activity. Now, what I will say about any of these physical activities, make sure that they can do these physical activities. You don't want to tell somebody who's never ran a marathon to run a marathon. You want to be realistic with your patients. So the advantages of some of this physical activity, decreased risk for falls. The more they move, the more their body's used to moving, the less likely they are to fall. Increased muscle strength and balance, increased mobility, increased sleep, reduced maintained weight, improved sense of well-being, increased self-esteem, reduced risk of diabetes mellitus, coronary artery disease, and dementia. So the more we move, the better it is for our patient all around. The main thing you want to focus on is functional ability. So you want to do these, I guess, you want to be building these strengths, you want to be building this flexibility to increase that functional ability. The main goal is for them to be as independent as possible. And that's what we want for everyone. We want them to do as much as they can. Now, that doesn't mean that if somebody went and broke their leg, you're going to force them to walk a mile. What it is for their capabilities, are we pushing them to the point that they can do things? The more you let people do, the better the outcome you'll have. So the next thing is that stress and coping. Stress can speed up the aging process or lead to disease. Probably not what you want to hear when you're in nursing school and your stress levels are through the roof. But honestly, you want them to have minimal stress. And I guess one of the worst things you can tell somebody who's really, really stressed is, hey, don't be stressed. But the thing about it is you need them to kind of work on how to be less stressed. Frequent sources of stress and anxiety, relocation. So a lot of these older adults are relocated to go live with family members. Like they'll be independent all by themselves, and then something happens, grandma, Mima, whatever you call her, Mimi, whatever it is that you call your grandmother ends up falling, and now she has to move back in with her daughter. Relocation can give them a lot of stress. It can give them a lot of anxiety because they're basically moving from this is what I did every day to suddenly being somewhere else. Changes in lifestyle. Once again, using that same thing. Grandma falls, breaks her hip, and now she's having to change roles a little bit with what she did before. She goes from giving the advice to her daughter to having to listen to what her daughter or her son is saying to her, whatever her child is. Acute or chronic illness, loss of significant others. So basically, the older we get, the more we see our loved ones kind of, for lack of better terms, fade around us. So we don't have them there with us. Financial hardship. This is what I was talking about before, where now they're on a set income. They don't have the same money that they had previously. Food insecurity. Do they know if they're going to have food for next week? Lack of transportation and or housing. So if they were living paycheck by paycheck prior to this, they get to a point where they can no longer do the job they did before. Now they no longer have a house. Falls. Whenever you see a fall, that's considered a trauma. So just start associating it now because you'll see this again when we get to MedSurg 3. Most of your falls do occur at home. Um, so that's why you want to teach them about safety, looking for things like, do they have a lot of rugs in their house? Is it well lit at night? What can I do to educate my patient to keep them from falling? Sensory perception changes. So basically, their vision may not be as good as it once was. drug use. So for example, when we talk about drugs, everybody always wants to jump to opioids or anything like that, but drug use is just any sort of medication. So thinking about it, that diuretic, they were told to take it at 6, they took it at 6 p.m. instead of a.m. Now they're getting up to go pee at night. Uh-oh, patient falls. So these are just things to kind of consider whenever you're dealing with an older adult. Some fall preventions, the study like STEADI. I've got a video on it that you can see on Momentum. Screening tools, assess modifiable factors. Is there anything that I can do to prevent them from falling? Can I tell them, can I educate them on using their cane instead of just walking without their cane? Clinical and community strategies. So trying to work as healthcare facilities, trying to work as the community to try to educate people. And honestly, health teachings. So teaching them safe ways to walk, teaching them that, hey, if you have to use your cane, it's better than you falling. And this is that video that I was telling you about um, that you can watch on YouTube that kind of goes through what this is. So the next thing is our medication use and misuse. One of the big things we see is polypharmacy, which polypharmacy basically means poly means many, pharmacy, medications. So this is multiple medications. Now this may be because they're going to several different doctors, or this may just be because they've got um, a whole lot of chronic disorders that require a lot of medications. So with this, one of the things that we do as nurses is kind of look for, do we have any duplicate medications? Is my patient prescribed 2 different blood pressure medicines, and are they even taking one? So that's something you want to assess for, is asking them, do they have the cognition? Well, don't say it like that, but asking them, are you taking your medicine? And you can be very straightforward with these patients of, are you taking your medicine at home? Because one of the things that I have seen happen in my practice is we used to have a lot of patients that came in and they would be on like 4 or 5 different blood pressure medicines. So since those were their home doses, they would say, go ahead and give it to them. What do you guys think happened when we gave them all 5 of those blood pressure medicines? You can pause it like Dora the Explorer again and ask it of what you think. Blood pressure went down, and it went severely down, because what happened was patient was prescribed something like hydralazine, went home, never took it, came back to their primary care physician. Primary care physician says, hey, your blood pressure is still elevated. I'm going to add carvedilol to it. Patient says, okay, goes home, goes back to the primary care physician. They're like, your blood pressure is still elevated. Let me give you something else. So they keep prescribing them these things. So by the time they get to the hospital, they've got all these medicines, and then we give them all of these medicines, and blood pressure goes down. The other thing is your high dosage of medications. So you might have some that have increasingly higher doses. Medication prescribed for too long of a period of time. Sometimes a patient may not necessarily need to take a medicine anymore. One of the other things I've seen in practice is you really have to explain to patients what PRN means, that it's only as needed. Because I ran into a lot of elderly patients who are given something like an opioid, given something like an anti-anxiety that was supposed to be just as needed, but they thought it was every single day. So without meaning to, they became addicted to said medication. So you just want to have them know that they need to frequently be checking these medications and see if they still need to be on them. Non-prescription or over-the-counter drugs, supplements. So another thing I've seen a lot of people do is take a whole bunch of different types of supplements without realizing that they're kind of making their own pharmacy altogether. And some of these medications can actually interact with the medications that they're taking. It's like something like grapefruit. Grapefruit's one of those great fruits that help you and everything, but it can interact with a whole lot of medications. So you just have to be careful with it. So some of the effects of medications on older adults. often intolerant of standard doses. So remember what I said, it's the very young and the very old. We have to take into consideration that these two populations of patients we have to be extra careful with. Sometimes they can't just be given the standard dose. They need to either be given, most of the time, they need to be given a dose that's smaller than the regular dose. Age-related changes. Absorption, distribution, metabolism, and excretion. Absorption, increase in gastric pH, decrease in gastric blood flow, and decrease in GI motility. So they're not absorbing it as well, so it may just be staying in their system longer. Distribution, smaller amounts of total body water, increased ratio of adipose tissue, decreased albumin level, and decreased cardiac output. So, for example, they've got something that has decreased albumin. If they have a drug that's protein bound, then it may not be working the way we want it to work. They don't have enough albumin for these little medications to actually hold on to. Metabolism, decrease in liver size, decrease in liver blood flow, decrease in serum liver enzymes activity, all means increased concentration of medications. So if we know they're going to have an increased concentration of medications, a lot of times what we're going to do is hopefully have the physician lower the dose. Excretion, decrease renal blood flow and reduce glomerular filtration equals slower excretion time for medications. So basically it's going to stay in our system longer. Chronic disease equals more medications. A lot of these patients are on opioids. Like I said, that's that thing where they told my patient, hey, it's PRN. They took it as I have to take it every single day. So just making sure that you're monitoring your patient. It's not that they're actively drug seeking, it's that they didn't quite understand the instructions. Watch your older adults and new medications. I cannot stress this enough. Is whenever a patient's on a new medication, and this goes for both older and younger adults, but especially your older adults, is you want to look for new onsets of confusion. You want to look for anything that may be because of these medications. Now, first thing you do always is stabilize your patient, make sure they're comfortable, make sure they're safe. All this stuff comes after they're safe. So, for example, patient comes in, older patient, very confused. I stabilize them. What do I need to do? I need to ask them what medications they're on. And the reason for that, I want to know about any new medications, is because I'm looking for something that caused them to become unstable. Maybe this medication affected their neurotransmitters. Maybe this medication affected how they process things. There's like a whole list of medications that can cause confusion in older adults. So like I said, always watch them with these new meds. Self-administration of drugs. So some of the things that they can do, forgetting to take drugs. So they'll just forget that they're supposed to take it. That's why these things here, these weekly pill organizers, are very, very helpful. Honestly, I do it for a lot of my family members. I make sure that all their pills are set up for the week, and it's just something like I'll just sit in the room with them, do it, and it makes it a lot easier. Poor communication with providers. This is where I talk about there's the way we speak, and then there's the way the patient speaks. And you need to be able to translate for both. You need to know that when a provider says tachypnea, that means fast heart rate. When a patient says it, they just say, I can't catch my breath. You need to be able to decipher what all of this means. So, the other thing is, sorry, I think somebody's coming. Sorry, I thought somebody was coming through my door. So the other thing that you want to kind of look for too is, are they using alternative medicine? Is there something along with their prescription medicine, like their traditional, like Western medicine, that they're also using something else? Are they also using acupuncture? Are they also doing something aside from just the medication we're giving them? And then the other thing is, a lot of them can just avoid taking the drug because they don't like the way it makes them feel. Assess medication use per healthy people 2030. So you just want to see um, which medicines they're on, how it affects them. The Beers criteria, it was first developed in 91. It's a list of medications that should be avoided, used with caution, or have their doses reduced in older adults due to risks outweighing benefits in most cases. So that's where it comes again, where we've got these older adults, so that we need to make sure that we're not giving them something that can put them at risk. Medication assessment every 6 months or more. So you want to encourage them to see their PCP, that's their primary care physician, every 6 months. And honestly, sometimes your best support can be the family, just talking to the family. If they've got a good support system, using the support system, and then also talking to your providers, pharmacists. The nicer you are to people, the easier it becomes to do these things. And then also look at your nursing safety priorities. Look at your drug alerts. Are these the type of drugs that are going to be very harsh on their kidneys? And if I already know that they're an older adult, then I'm going to be more careful about it. The next thing is your impaired cognition. So this is decreased reaction time to stimuli, impaired memory for recent events. So one of the things with this impaired cognition is your legal confidence. Is my patient able to actually consent? Because remember, in order to consent, they have to be of sound mind. They have to be completely aware of what they're signing for. If they are not completely aware, then it becomes a very tricky situation where you can end up having a lawsuit. You can end up being considered malpractice. So you want to make sure, are they completely confident when they took it? Did I give them an opioid right before I had them sign consent? And if you did that, does that count as like an appropriate consent? No, it does not. Because if I gave them anything that can mess with their cognition, then it's at that point, it's impaired cognition. And they were not of sound mind to actually sign anything. Clinical compliance or competence. Are they able to actually do the things that we're asking them to do? Prevention of cognitive impairment. So trying to work with your patients, trying to keep them active. We'll talk more about these 3Ds. Hold on. Sorry, I was saying if later in the lecture I've got them. So we'll talk more about these 3Ds as we continue, but with it, I just want to mention, so things like delirium, one of the ways that I can prevent cognitive impairment is making sure that my patients know day versus night. We used to see a lot of patients become very delirious in the ICU because what do we do in the ICU? We turn on all the lights and make sure everybody's awake all the time. Now, the issue with that is it can make a patient confused about their days and nights. So I'm going to go into more depth after we talk about a few things about these 3 different Ds and what they mean for your patient. Substance use disorder, excessive use, alcohol, illicit drugs, basically anything of that nature. It can affect their mood and cognition. It can cause them to become very isolated, depressed. Acute confusion can result. So something that I want you to kind of think about when you're going through these things, and this will help when you finally get into mental health, is think about the type of confusion you're facing. There's different types of confusion. There's different types of how your patient reacts to things. So with this acute confusion is it can be caused by the alcohol opposed to it being something that's a long-term cognition problem. And then we've got some tools, and on the next slide, we'll go ahead and go through the CAGE questionnaire. So the CAGE questionnaire is just 4 questions. Now, one thing I will say is when you go about asking these questions, a lot of times people are like, I don't want to ask them because I feel like I'll be rude. Sometimes you may be the only person who's asking these questions, so it's important that you go ahead and ask it. Now, I say that with like a grain of salt. If you're in clinical and your clinical instructor tells you it's not appropriate to ask those, then obviously don't ask them at the time. Your person of reference is your clinical instructor. But what I'm saying is when you go out into practice and you're on your own and you're with these patients, it doesn't hurt to ask them these questions as long as you're asking them in an appropriate setting and you're asking it in an appropriate way. So the 4 questions are, have you ever tried to cut down on your drinking? Some people just don't know that they can cut down on their drinking. They just have that lack of health equity that we talked about before, health equity. They were raised in an environment where you drink for dinner, you drink for morning, you drink all the time. No one's ever actually talked to them about alternative lifestyles like that. Have people annoyed you by criticizing your drinking? Has have you ever felt bad or guilty about your drinking? Have you ever had a drink first thing in the morning to settle your nerves? Eye opener. So these are all things that get them thinking. And in that moment, they may react poorly. And in that moment, it's not like not everyone's gonna have that aha moment and tell you, thank you for asking, but it may be something that they go home with and think about later. So asking these questions kind of get the wheels rolling, basically. Next thing I want to talk about is elderly neglect and abuse. Neglect, caregiver fails to provide basic needs for an older adult. So this basically means something like um, you might find an elderly patient that's been sitting in their stool all day. One of my biggest pet peeves when I'm in clinical, just in general, and this is just Professor Flourish's personal pet peeves, is whenever I hear a student tell me, oh, that is CNA work or that's UAP work. That's something that I won't do. The fact of the matter is, for me personally, even if I'm the one who's changing them, I cannot stand to leave a patient sitting in their own stool. The example I always use is, have you ever gone to the pool or the beach and had that ride home where you're sitting in a wet swimsuit? Now imagine if that was your urine. Imagine if you were in a bed and nobody came and changed you. That's pretty much what I always think about. So it's one of those things that I'm either checking them every hour, every 2 hours to make sure they're not sitting in that. And even if I have to like take an extra few minutes to do it, I'm gonna do it just because I just don't like them sitting in it. So for neglect, we're talking about these people who are just sitting in their own stool, something came up and they're neglecting. That's different than abuse. Abuse can be physical abuse, use of physical force that results in bodily injury. That means that somebody is hitting said older adult. Financial mismanagement or misuse of property or resources. So this would be something like my social security check. I give it to my son or my daughter. I give it to my child, and said child ends up using it for illicit drugs. That is financial abuse. You're using the money without helping them. That social security check isn't for you to buy illicit drugs. That social security check is used to help them survive. Emotional, intentional use of threats, humiliation, intimidation, or isolation. So that can be something like, we're going to put the elderly person in the corner. No one's going to talk to them because I want to make them so emotionally distressed, they do what I say. It can be something like humiliation, telling them like, oh, you smell like urine, you can't go out. It can be something like, if you don't do this, then I won't give you this. So you want to look for this when you have an older adult or an elderly patient come into the hospital to assess if there's any sort of misuse going on. So like I said, always assess for physical signs of abuse and neglect. Some of these physical signs may be something like they've got a lot of bruises, and it's not just, oh, my patient's an older patient and they have bruises. It's these look like very intentional bruises. With things like neglect, do they have a pressure ulcer? Do they have a rash on their sacrum? Something along those natures. Teach about scams. A lot of times they don't actually know about these scams, so you want to let them know that, hey, I understand that that link on Facebook looks very, very tempting. Don't click it. Um, it's like I knew of this one older person where somebody had sent them what's it called? Tickets to the zoo for like $2. And all that really happened is it was a scam to get all their information. You want to screen with appropriate assessment tools, so using the tools that we've got, and refer and report. So elderly abuse is one of those ones that you can report. It's kind of like child abuse because these are very vulnerable groups. If you don't report it, who will? Um, so health issues for older adults in hospitals and long-term care facilities. We've got these acute care of the elderly units, so these ACE units, nurses improving healthcare systems, the SPICE framework that we'll talk about, and then the 4 M's of an age-friendly health system. So looking at this framework here, we've got sleep disorders, problems with eating or feeding, incontinence, confusion, evidence of falls, skin breakdown. So it's one of these frameworks to help you assess your older adults. 4 M's of age-friendly healthcare. What matters? Medication, meditation, mobility. So things like when we talk about this cognition, so this meditation, um, are they cognitively able to sign consent? If they're not, what do we need to do? Talk to the healthcare team about it. Because if this is something that really matters, if this is a surgery they really, really need, then a lot of times 2 physicians can sign off for the consent. Looking at things like depression. Once again, this is where I was talking about that loneliness. It's very, very common in older adult populations. Their spouses died, their family has all passed on, and now they're just kind of by themselves. So you do want to assess for this very common mental health condition and just kind of saying like, hey, um, how are you doing? What is going on? Avoid things like, why are you so lonely? You never say the word why, it's not very therapeutic. And then on the next two, we'll talk about dementia and delirium. So delirium is characterized by a disturbance of consciousness and a change in cognition that develops over a short period of time. So that is the main thing, is short. So this is sudden. Who is at risk? ICU, post-op, older adults. How often should you screen for delirium? Frequently, usually at least twice a day. Honestly, whenever I had my patients, what's it called? At the in the ICU, I would always just screen to make sure that they're um, not getting confused, that they know their day and night. And all you really have to do is just do a quick level of consciousness. Do you know where you're at? Do you know what's going on? Things of that nature. Now, dementia is different than delirium because if my patient came in and they were fine and then all of a sudden they have this short period of confusion, I'm thinking of more delirium. Dementia is a progressive deterioration of cognitive function and global impairment of intellect with no change in consciousness. It is slow. So with dementia, this is progressive periods of forgetfulness. It happens over the past year. Delirium is basically my patient suddenly has this change, so I'm going to assess them. I need to make sure that they're not going to fall or anything like that. Dementia is progressive, so make sure that you know the difference between the two because somebody who's delirious does not necessarily mean that they have dementia. Now, somebody with dementia is more prone to become delirious, but make sure that you know the difference between those and the difference between these two and confusion. Confusion is a lack of understanding, uncertainty. So confusion is different than delirium or dementia. It can be caused by several things. It can be, like we said before, with alcohol. It can cause you to be confused. You can get hit on the head. You can have, what's it called? Respiratory issues, not enough oxygen, makes you become confused. Understand the type of confusion. I know you guys are still at the beginning, so it's maybe a little bit more difficult, but as you progress, you'll be able to kind of be like, oh, that seems like encephalopathy versus, oh, that seems like confusion because they don't have enough oxygen. oh, that seems like confusion. That's kind of more related to dementia. One thing to ask is, will hydration fix the problem? Do they have imbalanced electrolytes? Is this psych related? Auction always explore why your patient is confused. So always ask yourself what is causing the confusion. And without a doubt, your priority is falls risk. All right, everyone, if you've got any questions, please feel free to send me a message. And I think that's all I have for chapter 4. Thank you.